Hello, my name is TSehon, and I'm a student physical therapist at Regis University. I'd like to talk to you a little bit about our study on the effect of length tension on muscle function. But first, a little bit of background. It's important to know that muscular strength is one of the most common metrics for tracking patient level of function in their progress in physical therapy. If this isn't assessed or recorded accurately, then there is no validity in the information that it provides the examiner, patient, or possibly even the third party payer. To ensure accurate evaluation, the muscle is often placed in a neutral length to maintain optimal strength production of the muscle. The clinician must be more cognizant of this fact when working with multiple joint muscles, because they are subject to change at length at multiple points. There are several examples of this occurring throughout the wrist and hand, which leads me into our investigation. Our purpose was to use altered positions of the wrist and hand to look at their prospective effects on muscle function, the prevailing theory being that a muscle in a neutral position will be the most functional as far as its strength and EMG activation. We had 8 subjects ages 22 to 35 who participated in this investigation. It is important to note that all individuals studied are young and apparently healthy. This lack of variance may limit the value of the study to people with a more varied demographic. Participants' grip strength was measured with a hand grip dynamometer, and the muscular activation was attained via the amplitude of EMG recordings. Once recordings were obtained to ensure working equipment, the subjects conducted a maximal test of grip strength in a neutral position regarding the wrist and hand. This was critical because it set normalized values that all other tests were to be compared to. Participants proceeded to repeat the test for the other positions. Comparison of all of our data showed that in all 3 measures, the neutral grip position was the highest, most markedly in force development. There was one discrepancy to this pattern, which was elucidated by the flexor EMG values being higher than the extensors on average, as they were the agonist muscle group in prehension. This resulted in the flexor EMG values for the short hand grip achieving 108% of the normalized value. This possibly occurred because of failure to fully normalize and achieve a maximal contraction upon our normalization set. Ultimately, these results are consistent with the literature that a muscle that is too elongated will display an active insufficiency and a muscle that is too short will not have enough cross bridges to perform ultimately. This is clinically relevant because clinicians need to be sure that they are paying attention to the entire muscle when they are evaluating it. Furthermore, in treatment, this property of muscle enables a more specific and effective exercise prescription to maximize recovery. Additionally, being aware of this improves the assessment of body mechanics in the patient, which should be shared with them, educating them to improve their function and prevent injury.